Hey everyone, good evening. I'm Rebecca Andrews. I'm a primary care physician and the physician lead at UConn Health Connecticut Comprehensive Pain Center. We are here today. I'm with my colleague. I'll let him introduce himself in a moment to discuss our second in a series of 6 talks that we are doing through a grant provided by the DPH for Connecticut. It is reducing risk when utilizing opioids and pain management, informed prescribing through guidelines and shared decision making. We are going to start right on time, and I'm going to turn off the video just so that we can be sure that we have good quality of sound. And what we'll try to do is finish with a good 15 minutes or so at the end to answer questions. We find that there have been a host of questions at these webinars, so that will give you some time to ask about your own individual practices or patients. So moving forward, if you did miss the first talk, it was centered on how to start from scratch in your approach to pain management. It can be found on the website listed here at the bottom of the screen.
Good evening, I'm Kevin Chamberlin. I'm the co-presenter tonight, a clinical pharmacist with pain management expertise and a proud member of the Connecticut Comprehensive Pain Center. Together, myself, Dr. Andrews, and I, we work with another primary care physician, Dr. Jen Ozimek, and an addiction psychiatrist, Dr. Sarita Rao.
So learning objectives for today, we really want you to be able to know how to use some of the adjunct pain medications. The reason is we're looking at the risks and benefits of opioid use. And although they do play a role, and we will discuss the current guidelines, we want to give you a skill set outside of just opioids for pain. And we're going to talk about the benefits of shared decision making when you do utilize high risk medications. So just in reviewing pain management, appropriate pain management really is appropriate both from economic and quality of care viewpoints. It's a huge economic burden each year with the amount spent on managing chronic pain. And looking at the numbers, you know, chronic pain patients outnumber those with heart disease, cancer, and diabetes combined. So as we head into our talk, I just want you to think of that, but also remember that not all pain is bad. Acute pain is actually adaptive, and it helps you remember that you're injured and minimize harm, where chronic pain, which we're talking about today, is maladaptive. With acute pain being adaptive, as mentioned, you would expect the treatment approach to be a little bit different than that for chronic pain. I think it's also important to note here that under treatment of acute pain can lead to chronic pain. So when you're looking at acute pain, you're trying to use regional techniques and really attack it at its source. Chronic pain, we're looking at a variety of complementary treatments as well. There are 3 types of pain that you learned about when you were in school. There's nociceptive, neuropathic, and the newly termed sensory hypersensitivity. The next slide is going to go over some of these, but the last one is thought to be secondary to persistent neuronal dysregulation. This is actually one of my favorite slides. It gives you examples of the 3 types of pain, you know, ranging from nociceptive pain, which you think of as somatic and musculoskeletal, although sickle cell disease is included here, as well as inflammatory bowel disease. Then we have our predominantly neuropathic pain. This is more post-herpetic neuralgia, lumbar stenosis, pain associated with a spinal cord injury or after a stroke. And then over on the right in the green, we have hypersensitivity with the fibromyalgia. Irritable bowel is also found here. And then some of those harder to treat conditions like chronic fatigue syndrome. I just want to point out that in the middle, we have more and more conditions that are being called mixed pain syndromes. And these are things you see every day: sciatica, temporomandible joint pain, but we're finding that even osteoarthritis and chronic low back pain can fall into this mixed category. If you remember from our first presentation, the first thing we really need to focus on is a pain-appropriate history and physical. Without getting the details of the pain, we can't really determine what is the cause, and without knowing the exact cause of pain, it is really hard to tailor your treatment. The importance of a physical exam is not so much to diagnose the cause, although it can be helpful, but it also really helps you know what their functional limitations are. And all the while we're doing this, what we're really trying to do is establish a therapeutic relationship. Pain conversations can be steeped in emotions and frustration, and so it helps to have the patient know that you're on their side and that you want to help them feel better. This is a slide going over some of the pain scales that have been used. This is from the Practical Pain Management website. These can be used in conjunction with whichever functional goal you and your patient decide is most important to them. These are tools really to assess overall function, help a patient make a personal functional goal that's really specific to what they consider successful treatment, which is an important question to ask, and we'll talk about that more in our next talk on tapering. Both, using a functional goal and a pain scale can really help make sure that when you're doing a chronic pain follow-up, you are making sure that there's some objective measurement of improvement, not unlike looking at the A1C for diabetes or blood pressure management for hypertension. This also helps keep you with sort of objective-driven guidelines during your visits. So you can look at these, you can go online and read about them, but if you get comfortable with a few, I would suggest those are the ones that you use in your practice. So taking a pain history isn't as easy as you think. The Pain Center, the biopsychosocial model of pain, talks about everything from cultural mores to home support system, maybe education, what a patient brings into it with past counseling skills, etc. But there's also the items that are here on the right side of your screen that we want to work with the patient on, making sure we're using patient-centered interviewing so that they can tell we're really hearing their story and understanding where they're coming from, getting them to focus on functional goals that are, quantifiable so we know if we're hitting success. And then being empathetic. There's a lot of stigma around treatment of chronic pain. And again, most of this was covered in depth in our first presentation, but just as a reminder, these are the items that are important to a successful treatment, and there's a link that you can go to our previous talk. One of the reasons it might be worth going back and listening to it is we really delved into shared decision making. This is a concept or a mechanism that's used that shares the burden of the decision making between the prescriber and the patient. It's not a patient coming in asking for what they want, but it's not you just giving the patient what you think is best. Sometimes either the dosing regimen or the side effects aren't tolerated by that patient. And so this helps you come up with a treatment plan that you can both agree on. And there's a lot of evidence that shows shared decision-making increases adherence from a patient perspective.
Low risk, low dose treatment options are what we're supposed to use first. So we should really consider everything that you start as a trial for effectiveness and not a permanent therapeutic plan. This slide shows something that should be familiar, but maybe modified. So this is actually the updated WHO step ladder for analgesic treatment. Starting at the bottom left of the step ladder is pain education for your patient first and foremost. This can help reset expectations of being absolutely pain-free, which is not a realistic outcome in many patients. Along with that, though, are NSAIDs, PT, and OT, all of which appear at every step along the way. Also at every step, though, are the non-pharmacologic treatments from acupuncture to exercise that, when used in combination, can potentially limit the need for increases in various medications. I'd also point out that before you even step up to step 2, there's actually psychology, behavioral therapy, and psychiatry to help with those pain-related mental health conditions, as well as helping patients develop skills for their own self-management of pain. Everybody forgets about acetaminophen, it seems. Further to that, I'd say that everybody seemingly forgets how to best use acetaminophen as an analgesic. Dosing really needs to be done on a scheduled basis and at a minimum dose of 650 milligrams. The reason you don't use it as needed is really that it actually inhibits central prostaglandin synthesis, and this is optimized when you use a scheduled regimen. Data also demonstrates that appropriate dosing and frequency of acetaminophen can lead to as much as a 30% reduction in opioid consumption by patients. NSAIDs also decrease opioid consumption and can actually increase patient satisfaction. We have data later rather that compares NSAIDs and opioids. Similarly to acetaminophen, NSAIDs can be utilized even before surgery for pain control. And as we know, NSAIDs decrease inflammation. Not all NSAIDs are created equal. Over the next couple of slides, you'll actually see a sampling of the different variety of classes. And so if one NSAID doesn't work, you can try one from a different subclass. Failure of one subclass does not inhibit its use in the future or mean failure of whole of NSAIDs. There's actually good data now, in addition to trialing different subclasses, that if a medicine has failed for pain management in the past, retrialing that same medication at even the same dose can have better outcomes at a different time for the patient. So for example, if you tried something like meloxicam 15 milligrams daily for your patient's low back pain maybe 5 years ago, and it didn't really have much benefit, it doesn't mean that it won't work the second time around. This slide also feeds off of our previous presentation, and it highlights not only the number of options we have for pain management, but also reinforces the importance of knowing the cause and mechanism of pain so that you can tailor your treatment. The information contained in this infographic has been taken from a variety of sources, including the Journal of Pain and Symptom Management and the U.S. Cancer Pain Relief Committee. Anticonvulsants offer a specific pathophysiologic-driven treatment option. If you haven't used these yet, I'd start by reviewing their FDA-approved indications and their adverse effects and the titrations as appropriate. But to really be effective in pain management, you can't avoid this class of meds. And as an opioid-sparing or opioid-reducing approach, it's ideal.
So just to give you an example, I'm going to use my patient. She was quite a few years, almost a full decade out from a primary cancer and ended up with a diagnosis of metastatic cancer. After surgery, she had just persistent right thoracic pain. And although the description of her pain was neuropathic, she had only been given opioids after surgery. In the room trying to decide the treatment, I work with residents, and so was a resident who saw the patient with me, and the resident physician heard the word cancer and immediately jumped to opioids as an option, even though the patient had said that the surgeon had tried them and they really had not helped. We ended up starting a regimen of scheduled acetaminophen at 1,000 milligrams 3 times a day, celecoxib, and gabapentin with near resolution of her discomfort.
As an example, this slide shows the differences between the two gabapentinoids, as well as dosing minimums as it relates to their effects. The evidence for SNRIs continues to evolve. Shown here is data from 2010, published in the British Journal of Anesthesia in regards to postoperative pain after a total knee arthroplasty. SNRIs are also frequently used for chronic pain, and they each have individual FDA indications, although they're often used off-label interchangeably. I'd suggest for greatest success to choose the one where the FDA approval matches the indication you're using it for. Because chronic pain and depression often coexist, though, you can get treatment of 2 conditions for the price of 1, really. Although used more frequently for neuropathic and hypersensitivity pain types, an effect cannot be ruled out in nociceptive pain in common conditions such as osteoarthritis. We don't want to dive too deeply, but pre-surgical treatments like anesthetics have advanced in a variety of ways that can delay surgery as well as reduce post-surgical pain. Skeletal muscle relaxants have been shown to decrease discomfort and accelerate recovery in acute situations. There are no randomized controlled trials, though, to support add-on use to NSAIDs or comparative efficacy to NSAIDs in chronic pain, although we often see them used that way. So some caveats with skeletal muscle relaxants. Cyclobenzaprine has a chemical structure similar to tricyclic antidepressants, so be mindful of the anticholinergic-like adverse effects. But these can also assist with various pain syndromes. We'd even suggest avoidance of carisoprodol as it's metabolized to a barbiturate. You really want to tailor the skeletal muscle relaxant that you use based on its peripheral or central condition that you're treating. The benefits of muscle relaxants really are short term though. Once you're beyond 5 days of use, you've had about a significant loss of efficacy. And beyond that, you really risk significant side effects. A marker to determine duration of use that we would suggest is muscle spasms on exam. As we said earlier, low dose and low risk first is a good rule of thumb. So let's not forget about the topical analgesics, especially when patients want to avoid pill burden. Lidocaine patches can be difficult to get approved through insurance. So know that the 4% over-the-counter version is considered equally efficacious to the 5% prescription version, and even so that many hospitals have even switched their formulary product to represent such. Of note, there's also topical diclofenac for a topical NSAID for use.
So we bring this up, again, my patient's a perfect example of how pain management is a discussion that sort of develops over time. She had significant GERD symptoms from the oral NSAID use, so we had to stop the celecoxib. I did keep her on the acetaminophen, and I pushed the dose of gabapentin to 2,400. And then I had to transition her to a topical NSAID, and this actually had really good effect with the complete resolution of her GERD symptoms.
We'd be remiss if we did not include herbal medications that actually have some data of support for their role in pain. We did not include other treatments such as magnesium or vitamin B12, which do have proven efficacy in migraines. We listed here on your screen a few options you and maybe your patients might be interested in. That statement comes with a public service announcement, though, that herbals and other nutraceuticals are really not regulated by the FDA for content or consistency. Thinking back to that WHO stepladder I showed earlier, psychosocial support and counseling, specifically cognitive behavioral therapy, is helpful for patients to learn non-pharmaceutical methods for managing their pain. We also have listed here complementary therapies that patients may be amenable to. Additional options not to forget are the actual physical therapies. There are multiple modes of massage, as well as techniques done by physical therapists such as Graston, cupping, and even stim. The challenge with some of these therapies, though, is that the evidence base is still developing, so you need to be aware of changing data on efficacy. In summary, this slide highlights the modalities of pain management on the left that should always be in use and that the patient can alternate between depending on effectiveness with relatively low risk. Currently, there is cost though, and hopefully our healthcare system will adjust to paying for these therapies going forward. The right side of the screen lists the categories of pharmaceutical treatments that we have discussed thus far.
So now we're going to talk about best practices when using opioids. Opioids are another medication class used in acute and chronic pain. There has obviously been a focus on increasing safety when patients require their use that's dictated in part by the 2016 CDC guidelines on using opioids for the treatment of chronic pain. So as mentioned earlier, treatment options really need to be based on history, physical, type of pain, patient preference, strength of evidence, and then used and tailored to the condition. Opioids are meant to be used when a patient has moderate to severe pain and has not found adequate relief with lower risk medications. A key is to start with a low dose of opioids and low number of pills prescribed and to use a functional goal as a measure of objective improvement. These are a trial. Just because you start opioids, they are no different than other medications. It doesn't mean you continue them. If they are not meeting the goal that you have set, or maybe your patient has been stable for some time and you want to try to taper off, consider de-escalation. If they're having side effects, consider stopping. And you really need to readdress the risk and benefit opportunities at each visit. We'll have more about this in our upcoming taper talk, but consistency is key for the same patient visit to visit and then across patients as well. And when you do decide to use opioids as part of the treatment regimen, if you remember nothing else about prescribing them, this slide would have everything that you need to know. There is truly no absolute indication or diagnosis specific to opioid use. There are guidelines in the surgical and medical literature that have best practices, such as the number of pills and the length of time to prescribe. We have some listed here from Hopkins, Mayo, and the Washington Agency Medical Directors Group. In acute pain, you want to think low dose, short duration, 3 to 5 days of treatment and then off. An example taper of someone post-surgery, you might have someone for 1 to 2 days at Q6 dosing and then Q8 dosing, etc., saving that last dose for nighttime for sleep comfort and healing, or prior maybe to physical therapy. Gone are the days where we would write a prescription for Q6 hours PRN with a 30-day prescription, and we'll show you some data as to why. Just keep in mind that previous exposure or use could influence the analgesic efficacy and how you taper, so not everything is cut and dried and easy to follow as a rule book. Opioids should not be used alone. When we use them alone, we increase, unfortunately, the risk of tolerance in our patients and addiction. And long-term treatment requires that you have an objective and measurable goal with your patient, that the benefit is well worth the risk. So for example, if your patient has severe osteoarthritis working on a concrete floor all day, being able to complete a 6-hour shift, or maybe an elderly patient who again has low back pain, who wants to be able to complete their grocery shopping without stopping to rest. Because there are significant adverse drug effects such as hyperalgesia, hypogonadism, constipation, sedation, respiratory depression, addiction, chronic abdominal pain, urinary retention, and many more, you really do need to sit down and review all of these risks with your patients.
On this slide, you're looking at the CDC guidelines for prescribing opioids for chronic pain. We've touched on most of these, but as a reminder, we really should be using the lowest effective dose. We should assess risk and mitigate it by using adjunct therapies, medication holidays, de-escalating treatment, and screening for risk of addiction. It should be best practice to review the state's database for prescription drug monitoring, and it also mitigates the risk of co-prescribing, which may lead to overdose and/or death. The use of urine drug screens as a means of assessing adherence and preventing diversion is also best practice. We need to avoid concurrent sedating medications, and remember there's a boxed warning on opioids used in combination with benzodiazepines. Identifying patients with opioid use disorder and offering treatment is also a major component of these guidelines. Much has been said about the CDC's use of 90 morphine milligram equivalents as a marker of concerning doses. This is really because increasing doses greater than 90 morphine milligram equivalents has shown limited to no benefit and is associated with significantly increased risk and adverse effects. When you do prescribe opioids, be sure to start, continue, and don't hesitate to change adjunct medications, as well as non-pharmacologic interventions to maximize pain relief. No one treatment, as shown in this study here, works better alone than in combination. While we are exploiting the synergism for positive effects, we have to be mindful of the negative effects as well, such as antiemetics and antihistamines, which can actually potentiate the adverse effects of opioid therapy, things like euphoria, sedation, and urinary retention. Delving a little deeper into the absolute and relative contraindications, be aware of both. Note that active untreated addictions are an absolute contraindication, but for a patient in recovery who is in pain, you can have a discussion of how to effectively treat the pain and limit the risk of reactivating that addiction if opioids are necessary. Be mindful of psychiatric disease that could be impacted negatively by opioid use, including high risk for suicide and pulmonary conditions such as obstructive sleep apnea and chronic obstructive pulmonary disease. Typically, we use doses 25 to 50% lower in the elderly. I think it's worth explicitly stating some of the benefits and harms. The goal is a balance of decreased pain with increased function and quality of life, with a clear understanding that full eradication of pain is rarely possible. And in that process, you're risking some potential harms, including making pain worse, causing falls, accidental overdose, and even depression.
The New England Journal of Medicine published an article in 2020, and I think this table from that article encapsulates so many of the complexities surrounding opioid prescribing. This shows the myths that we have, both us actually as prescribers and our patients, that sort of drive underprescribing of opioids. One is that there's no role in long-term opioid therapy. And although we do discuss that there's very limited evidence, there are times when it needs to be utilized. And the other myth is that the side effect profile of opioids poses unacceptable risks. And again, the reality is all medications have side effects. When you prescribe a statin, you have to do the same shared decision making when talking about risk versus benefit, especially as your patients age and you're talking about primary prevention. The key is to identify if the benefit actually outweighs the risks, and then therefore it is acceptable to use. Chronic pain is always a challenge to treat, so resetting to that functional goal that you should set at the start of opioid therapy has helped identify when the medications, even the adjunct medications, are having a beneficial effect. Many only provide modest benefit, about 30% no matter what medication you're choosing, decrease in pain, and then frequently utilizing multiple drug classes is often required to get people to obtain their functional goal. Conversely, though, there are also myths that contribute to overprescribing. The thought that opioids are somehow the most powerful or the strongest medication, and we know that that's not true. There's little evidence that opioids are superior to non-opioids for pain, and in fact, sometimes they're not even as effective. This holds true both in acute pain as well as the trials finding no advantage over NSAIDs. The last myth is that the risk of a resultant opioid use disorder or unintentional long-term use is low. Honestly, any opioid prescription is associated with a meaningful risk of resultant long-term use, even if that's not what you and the patient are hoping for in the beginning. And we'll show you just how likely that is shortly.
Here's a brief summary before moving on. There's no specific, quote, opioid appropriate disease process. Opioids are indicated in general if the patient has a moderate to severe pain that is not responded to other treatment modalities and is limiting functioning. They should only be used as part of a multimodal therapy approach. And prescribing should be considered an opioid trial and only when benefits are projected to outweigh harms. Here is an example from Hopkins on how to manage post-op pain with a version of the eat this, not that sort of menu. It highlights what you should start with before trying opioids and also gives a maximum pill count if you do prescribe an opioid. This is why that taper we mentioned is so important. You don't want to undertreat the acute pain, but pain is also adaptive. It helps remind you not to overdo physically while you're healing. So the taper, if an opioid is needed, will help the patient convert to non-opioid therapies as they heal. Not all pain requires treatment with opioids. A major barrier to appropriate dosing of opioid analgesics is that it's difficult to predict the intensity and the duration of pain after an injury or surgery. Pain varies depending on the type of injury or the surgical procedure, patient demographics, cultural factors, a prior history of alcohol, drug, or opioid use, and the history of anxiety or depression. Bringing us back to the evidence, this SPACE trial from 2018 exemplified the reason opioids are not a first option. They were not superior for pain-related function over 12 months in patients with severe chronic back pain or hip or knee osteoarthritis pain when compared to other lower risk options. And if you're using the evidence, currently the low risk meds perform at least as well as opioids based on the 4 studies seen here from 2010 to 2018. Just some final points on opioid prescribing safety. Be aware of the incomplete cross-tolerance that exists when switching between opioids. The tolerance a patient has towards one opioid may not completely transfer, thus incomplete cross-tolerance, to the new opioid. So if you're switching from one opioid to another, we recommend to start the new opioid at 50% of the equianalgesic dose. The information here is actually from the UConn Health Pocket Pain Guide, which most institutions also have.
This is a slide just to remind us all that from the legal viewpoint, no matter what state you practice in, opioids have been deemed high enough risk that there are prescribing laws that exist. I just want you to be aware of this in your state statute and to check base because they are always changing. All right, discontinuing opioids. We are going to steal a turn of phrase here from David Gerling, who both of us love to follow on Twitter. If you don't know how to land the plane, then you shouldn't be flying it in the first place. So we want you to have some reference on how to decrease opioids safely. We do have an upcoming talk that focuses on tapering specifically. I think I would start by saying the hardest conversations to have are always the ones that are most worth having. The discussion on discontinuing opioids is challenging because most patients have the same belief system surrounding opioids that we discussed earlier from that New England Journal article. They believe they are stronger and better, and by removing them, there's no hope of healing their pain. This creates an emotional bond or commitment to the medication that involves the fear of it being discontinued. So we wanted to walk you through some of the reasons to discontinue an opioid and start by clearing the air with the reason that everyone thinks of first, which is diversion. This is a time when abruptly stopping the medication prescription is an option, since they're not taking the prescription you're prescribing, they're actually selling it or giving it away or exchanging it for some other substance. And by continuing to prescribe it, you're actually facilitating the illegal activity. You might not have read the DEA instructions very closely, but if you delve into them, this is a do not do as a prescriber when you get your DEA license. There's no perfect way to determine diversion, however, so it can be a little bit stickier than that. Using the prescription database, urine drug monitoring, or pill counts are mechanisms that you can use. They're just not fail-safe. Active addiction is also a reason to discontinue the opioid. But please don't just stop the opioid. We should be offering substance use treatment at the same time for these patients as they're self-medicating for a biological condition. Failure to treat a functional goal or having a serious adverse effect are two reasons to discontinue this high-risk medication, and I think those are the two reasons that are hardest to find. So it should be critical at the time of starting the opioid that you review with them that this would be a time you would stop it, that the benefit has to continue to outweigh the risk because it is a high-risk medication. So also paramount is a measurable functional goal so you can continue to assess efficacy. You can try just lowering the dose if it's a less urgent adverse effect, such as urinary retention, that you think might respond. But if there's no improvement or it's a more dangerous adverse effect, stopping the opioid is the correct and safe decision for the patient. We just want to taper and discontinue with compassion. And I know as we sit here tonight, you're probably thinking to yourself, who would continue to prescribe an opioid for a patient after a non-fatal overdose? But this study from the Annals of Internal Medicine in 2016 showed just that. 91% of patients continued to receive prescriptions from someone and 70% from the exact same provider. 7% had a repeat overdose. And the patients in this 7% cohort also tended to be on the higher dose opioids and or a concurrent benzodiazepine. So while we need to be vigilant about preventing risk of overdose, we also have to admit that there is a new phenomenon of opioid orphans, and those are a serious concern. There are some patients who have followed the prescriber's regimen to a T, have never misused their medication, but maybe their prescriber is retiring or moving or changing practice location, and these patients struggle to find a new primary care provider to continue therapy. We need to be cognizant of two things. One, that having a patient on long-term opioids means we should be helping them find continued care before we leave them, understanding what the struggle for this, if they're left alone, will be. And two, if the patients are abruptly discontinued because they can't find care, those patients who have been stable and following your regimen with good pain relief might be thrust into withdrawal that can cause uncomfortable or even painful symptoms. And at this point, they may exhibit behaviors that have a new prescriber concerned for substance use disorder, but we need to own the responsibility that we have created a sense or a state of opioid dependence and tolerance.
So with that thought process, opioid tapering can be a scary time for patients. Prescribers may be worried about their patient turning to illegal means for pain control or even abandonment in their pain management treatment. But tapering can reduce the development of tolerance and offer the opportunity to reassess continued need of a high-risk medicine. Additionally, reasons to taper range from alleviating unacceptable side effects, reducing potential for diversion of medications, addressing the failure to reach a functional goal, and to meet the patient's desire for less risky medication use. Tapering should begin by decreasing the dose first, followed by the frequency of dosing once at the lowest milligram option. If this is not tolerated, decrease to the lowest tolerable dose and then decrease frequency if able. Published evidence illustrates success for patients on high daily doses and a willingness to taper. Many of the medications used to alleviate withdrawal symptoms, like opioids, need to be used with caution in those patients greater than the age of 65. So stay tuned for our future talk that goes into detail on tapering.
So one last aspect that makes prescribing long-term opioid therapy inherently challenging is the iatrogenically induced tolerance, dependence, and addiction. Unfortunately, acute pain is more difficult to control when a patient has tolerance, and we see this in studies looking at post-op pain. The pain is found to be 3 times more severe, requires 3 times more opioids for control, and even when looking at epidural use, they're used for 3 days longer. Also remember that we're partnering with our nursing staff, and they get quite nervous and uncomfortable when they're looking at prescribing someone 300% more than their average patient. I'm going to touch briefly on opioid disorder because this is an adverse event that's potentially preventable, if not as serious as respiratory depression. If you're going to prescribe, you should be screening for high risk of addiction, as you and your patient should be aware of what their risk is and discuss it before ever writing that first prescription. This slide is from an article in 2017, just highlighting some screening tools that can be used, as well as indications, advantage, and pitfalls of each. I've highlighted the ORT, which can be done in less than 1 minute in the office before prescribing. The opioid epidemic is not new, and it's not disappearing. This slide shows 3 iterations of opioid-related overdose deaths from the National Vital Statistics System mortality file. Looking at 1999 to 2016, more than 100,000 people died from an overdose involving an opioid. And this could be prescription, illicit opioids, or combined. This first wave, which is here in purple, began with increased prescribing of opioids in the 1990s. So that's what we were doing. The second wave in orange began in 2010, and this was a rapid increase in overdose deaths. As prescription opioids increased in cost, people went and started using heroin again. And unfortunately, heroin, which was less dilute than previous use, caused a lot of unintentional overdose deaths. The third wave, which began in blue, and began in 2013, these are deaths that are involving synthetic opioids, particularly, at least in my area, illicitly manufactured fentanyl. Although the market continues to change, it can be found with a combination of controlled substances in it. It's very cheap to create, and it's very easy to sell on the street. Most overdoses now have more than one substance in the person's bloodstream.
The reason we spent so much time about short-term prescribing is highlighted right here. Almost all the guidelines will say less than 7 days in acute situations or as a first trial for pain management. And as you see here, at about 5 days, the likelihood of dependence increases. Note that 3 years out, nearly 25% of patients prescribed opioids are still on them if given a 1-month supply at initiation. So how can we safely prescribe while reducing risk of causing overdose, unintentional long-term use, or addiction? By being hyper-acute of what our prescribing habits are. 46% of patients receive 7 days of opioids at their first visit regarding pain with their PCP. And of these patients, 10% get a whole month's supply. I hope we've convinced you today that this should not happen, that lower risk medications need a trial first. In fact, multiple lower risk medications should be utilized before writing for an opioid. And remember, high doses equal higher risk, and long-acting formulations lead to long-term use. Medical and surgical subspecialties need to work together in growing awareness as we hand off a patient in care. This study in the British Medical Journal in 2018 focused on postoperative pain management. Each prescription refill increased the rate of misuse by 44%, and each additional week prescribed increased misuse by 20%. As a country, we approach pain in a manner that sets us apart, and not in a good way. The US contains 5% of the world's population, and yet we're responsible for 80% of the world's prescribed opioids. Most often, we worry about addiction, but there's a new concerning trend emerging, one of opioid misuse. Misuse is defined as use contrary to how directed or prescribed. It's a pattern of use, regardless of presence or absence of harm or adverse effects. Studies from 2015 and 2018 show misuse, although hard to measure, is found in more than 20% of patients prescribed opioids. Misuse can be your patient asking for an early refill, saying they increased the frequency to every 4 hours because it wasn't working, or taking the opioid you prescribed for their knee surgery for the back pain that started last week. Red flags are meant to grab attention. In pain management, these flags fall into 3 categories: the behaviors, the stories told, and the patterns we see. Utilize these flags as a possible warning of misuse or opioid use disorder, but don't be too quick to judge.
So how do you determine when misuse or tolerance becomes actual addiction? This slide contains the characteristics of addiction, but this will be reviewed in detail in an upcoming talk, so stay tuned for now. Although that talk will have more detail, today is about safe opioid prescribing, so I want to at least review some of the patient-related factors that were found from 6 studies that place a patient at higher risk for misuse, overdose, or addiction. There's age, family history of substance use disorders, history of a mental health disorder, especially if active or poorly controlled, past history of abuse, past legal issues, and then sleep disordered breathing also is a risk factor for overdose. The prescriptions we write also carry inherent risks of overdose and addiction as well. So if you have a patient on more than 100 MME, if they're on it for longer than 3 months, the long-acting formulations, combinations with benzodiazepines, which are now a boxed warning. And I will highlight for acute pain, addiction risk goes up with any number of refills. So keeping them only to that one refill, that one prescription, and then changing medications is important. And risk of overdose is 4 times higher if co-prescribed benzodiazepines with your opioid. This epidemic can only be halted if everyone, patients, public health officials, physicians, advanced practice providers, pharmacists, nurses, everybody understands the risks. Prescription drugs are the new gateway drug, surpassing marijuana. And in 2004, for the first time ever, they surpassed alcohol as the reason for entering a publicly funded addiction treatment program. So given that over 70% of post-op opioids are not used and the risk associated with use, especially for younger patients, we need a complete overhaul in how we think of pain management, and we need strategies that we can use to prevent addiction. For our adolescent patients, honestly, we just need to do better. We need to prevent the 33% increase in use of opioids for non-medical reasons by age 23 if they've already been exposed to an opioid. We need to screen for risk of addiction before prescribing, and we need to use non-opioid treatments first.
Just like you need to know how to safely discontinue an opioid before prescribing, you need to prescribe naloxone for overdose prevention. Any patient on 50 morphine milligrams or higher and or on other CNS depressant medications with their opioids can have their overdose risk reduced by close to 40% with naloxone. We've given you a fair amount of information today. We will take the next several slides to quickly review some final take-home points.
So I just want to start with clarification of pain. Use your history, imaging, physical exam to identify the patient's pain syndrome, and chronic pain really is not enough of a reason. Tailor the treatment via the literature to that condition. This is our final plea for multidimensional care. Chronic pain treatment is focused, yes, somewhat on pain reduction, but actually more on quality of life, restoration of function, reduction of pain, improvement of quality life, and how to cultivate well-being should be the 4 kind of pillars of your treatment plan. The red box on this slide in the upper right reminds us of the limited data for opioid use and chronic pain. And given everything we've talked about, although we did this in the first talk, having a specific goal for treatment, not to be pain-free or a pain level of 0, and being willing to discontinue a high-risk medication if you don't achieve that is very important for you and your patient. So thinking of my patient earlier with a metastatic cancer, swimming is something that had brought her peace and relaxation her whole life. She wanted her pain controlled, not just because of the pain, but because it was limiting her ability to swim. She had had extensive surgery and was preparing for chemotherapy, and she really felt like she needed to be able to swim to manage the mental strain and stress of going through chemotherapy. So for those of you who have not heard of SMART goals, we have this slide up here. And for my patient and I, we were specific. She just wanted to be able to swim again, measurable, working up to 30 minutes. Was it attainable? I mean, we're in the time of COVID, so we had to find an open pool and examine the cost. We wanted to be realistic, so start with 10 minutes of swimming, but then add in stretching. And then we were time-based, so we would know if we were successful or not. So just before we finish, take a moment and pause and reflect before you prescribe an opioid. I would love if you could think these questions in your head to yourself. Is this treatment that I have tailored to the pain before starting an opioid? Have I tried multiple low-risk options? Is this an inherited opioid plan, or am I choosing this treatment for my patient? Is it solely the patient's unwillingness to try alternate medications that has me prescribing, and does that make me feel uncomfortable? Is there a misdiagnosis that's worth reevaluating, re-imaging, or retrialing of medications before we start the opioid? Have I screened my patient for substance use disorder or risk of opioid use disorder? And most importantly, am I 100% sure that the benefit outweighs the risks?
To summarize the evidence, there's limited data to support safety and efficacy of long-term opioid therapy. They are more of a last resort and should never be used alone. Patients need to be aware there are times you will decide to taper and discontinue. There's evidence that the majority of patients are willing to taper if approached. And the risk of overdose is 4 times higher if co-prescribing opioids with benzodiazepines. The discussions on tapering and stopping opioids can be emotionally charged given the belief systems that many patients have built around opioids. Success happens when good rapport has been developed, along with a pattern of open communication and utilizing shared decision-making. A future talk in this series will go in depth into these techniques, and one was reviewed in the first presentation. Chronic pain management requires a constant assessment and reassessment of meeting goals, deciding if we need to change therapies, and calculating a risk-benefit profile. So stay tuned. Lastly, this is our homegrown and published tool we use to teach the stages of acceptance we see patients go through with changes in pain treatment plans. It helps the clinician anchor the emotions of the patient to a modified version of the well-known stages of grief model from Kubler-Ross. This helps preserve the empathy in the face of a challenging conversation.
So initially, when we started this series of 6, we promised 1 skill for each of these presentations, but we felt like there was a lot of information in here that was just too important to cut out. So we used the quickest, which is the ask, tell, ask communication style. It's effective because you can use it to illustrate that you have truly heard your patient's story while getting the chance to tell them your perspective and explaining to them why you're choosing something that might be different than they were hoping to get for their pain management, or resetting their goal of a pain for 0 to actually using a functional goal. This skill is a good methodology because it allows the patient to feel validated but also clarifying the medical decision-making behind our treatment choices. And then just before we wrap up, a big thank you to the Connecticut Department of Public Health who made this possible through the grant funding from Overdose Data to Action. We look forward to having you and more of your colleagues at the remainder of our sessions that will happen over the next year. Let's see if I can effectively get the video back up, and then we'll take some questions. If you have them, you can put them, there's like a question and answer, and there is a chat function.
So the only question we had so far was about if the copy of the slides would be made available.
So we had one question about getting a copy of the slides. This will all be posted up on our website, which you can see down at the bottom of the slide, health.uconn.edu/pain-center. And it will also include the first talk. Our third talk on opioid tapering will happen in June, and then we will take a break for the summer because we know everybody needs some family time, and we'll pick it back up again in the fall. Are there questions or comments? We're going to hang out here for a minute in case anyone has some, because sometimes they pop up at the end. Let's see. How do you work with a patient who's resistant to your treatment plan? That's our next question. I would say gingerly on one hand, but also very transparently. I think if you use true empathy and show that you have heard how they have suffered, they feel like you are on their side and looking to help them. And if you continue to be empathetic about how it would feel to wake up every day in chronic pain, it buys you a lot of currency because you care for them when you try to delve into possible options. I do think you have to be transparent. The literature says, most medications that we use for pain do not reduce pain that is chronic more than 30%. And even with that, sometimes you need a combination to get that low. And that's why you really need a functional goal. So sitting down and talking to them and saying, what is the one thing that your pain is getting in the way of that you just, want to get back to doing? Or even asking them, what do you consider success? It helps you know where their mindset is. So if they say they want to be pain-free, it is very unlikely to happen. And so then you can start there in educating them. Although we didn't talk about it in this talk, we'll talk about it in the upcoming talks. There is benefit from cognitive behavioral therapy to have your patient work with therapists who do work in chronic pain to help reset their skill set, what they can do for themselves to kind of reduce the catastrophizing that happens surrounding pain, and also get them on board with what are realistic goals. And that gives them some sense of control. And then sometimes we bargain, like we say we have to try medications for a certain amount of time. We're not going to leave them alone. Using frequent follow-up or a way to get in touch with you every week or two, maybe via an electronic health portal or by frequently coming in for visits. All of that gives them the sense that they're not abandoned, even if they don't love what your plan is.
There's a question about how do we feel about the use of the PDMP?
Do you want to take this on?
I'll start with it, but I'm going to hand it to you after. I think, there's been a ton of improvements to the PDMP software over the last 12 months. With the real-time uploading from the pharmacies and the dispensaries, the inclusion of medical marijuana, we're always up against not having information on somebody that might be on methadone for opioid use disorder, but that's a larger issue at the federal level. And, maybe someday that will change. I think the information that is available there is very helpful. The calculation of the NARC score, the calculation of morphine milligram equivalents based on CDC conversions. And then I would also tell you that it's not just enough to just go in there and use it, though, and I think this is where I would hand it back to you, is you can check it all you want, but if you're not documenting that you're checking it in matters of litigation, it didn't happen.
Yeah, so I think, one of the things is, again, knowing what your state laws are. So in Connecticut, we're required to check it at least every 90 days. So getting the habit of checking it with every prescription and documenting either on the prescription or in the chart that you checked it is important. This is all means of reducing accidental overdoses. There's a lot of stigma surrounding substance use disorders, and opioid use disorder is no different. The patient might have a hard time coming clean about that because they don't know how you're going to approach them. So this also can help you identify someone with a substance use disorder. You check in the database and you see they've got 3 or 4 people prescribing. You can actually show them the screen and say, let's have a conversation about why this is risky, and let's try to get to the bottom of what's going on. Now, sometimes it just shows you that they've switched from prescriber to prescriber because they don't feel their pain has been adequately treated, but at least it gives you the opportunity to try to intervene if there is a substance use disorder and really affect someone's life in a positive manner. You can, in your office, have a delegate who checks for you. We don't do that at my office, but you can, and remove some of the quote unquote paperwork burden because they can send you that information. I'm the prescriber. I'm the one with the DEA license. I want to know that I checked and looked at everything I was supposed to. So I look for myself. And it also, the majority of people who overdose from opioids, they're the people you hear about who just died overnight in their sleep. And I don't ever want to question if there was something that I co-prescribed or a dose that I prescribed and I didn't know enough about what else they were on. So those are some of the reasons to use the PDMP. It is, it's an extra step, but it's worth doing.
I think the last thing I would add is, if you're at a health center or an institution where you use it and you have the ability to have it integrated into your EMR system, there's new federal grant dollars that recently were released to the state, and the governor made an announcement maybe a month or two ago that, they will assist in getting that integrated directly into your EMR, and it'll be a one-click check ability for providers. So that's awesome.
Other questions? I'm trying to check both the chat and I think we don't have any more questions. We have just a few minutes left. We did add a couple of slides on functional assessments that the first group, we do each of our talks twice, for the early morning crowd and then for the evening crowd. So, feel free to send in through the pain center or to our personal emails. You can find us online at UConn Health. Anything that you think you need to safely treat pain, and we'll add it into the upcoming talks. Thank you all so much for attending.
Thank you.